Case 1, Compartment Syndrome. We're kicking things off with a scenario that requires high energy and absolute urgency. Okay, picture getting this exact handover in the ER. You've got a 24-year-old guy brought in after a bad motorcycle accident. He's got a mid-shaft tibia fracture. 4 hours after applying a back slab, he starts developing severe pain, and it's worsening despite IV analgesics. Crucially, and listen to this part, the pain is excruciating on passive stretching of the toes. His leg is tense, it's swollen, but his dorsalis pedis pulse still totally palpable. Take a second. Think about those clues. What's the most likely diagnosis here? If you immediately thought of acute compartment syndrome, you are spot on. This is a literal surgical emergency, and an important IMM pearl to file away right now. The absolute most common cause of compartment syndrome is exactly what we just saw in that scenario, a tibial shaft fracture. Let's break down the classic clinical features, the famous 6 Ps. The examiner really wants to know if you understand the timeline of these symptoms. Notice that pain out of proportion is your earliest sign, and pain on passive stretch is the most sensitive clinical feature. But look way down at the bottom of the list, pulselessness. This is a really late finding. Actually, if you wait for the pulse to disappear before you diagnose compartment syndrome, you've waited entirely too long. The damage is done. And remember, the best initial investigation is simply your own clinical diagnosis. Do not, under any circumstances, delay treatment waiting for a scan. So, how do we manage this the second we diagnose it? First, immediately remove all tight casts, splints, and bandages right down to the skin. Second, keep the limb exactly at heart level. Third, get them oxygen and analgesia. But the definitive treatment, that is an emergency fasciotomy of all involved compartments. Time is quite literally muscle here. Skeletal muscle is incredibly sensitive to ischemia, and irreversible damage kicks in after about 6 hours. You have got to get this patient to the OR. Let's quickly clear up a couple of classic MCQ traps that trip up so many candidates. Examiners love to suggest that normal distal pulses completely exclude the diagnosis. The reality? Like we said, pulses are often present until very late in the game. Another huge trap, elevate the limb as high as possible to reduce the swelling. No way. You must keep that limb at heart level to preserve whatever arterial perfusion is left going to those starving muscles. Don't lose easy points on these examiner tricks. So, here's your golden one-liner memory tip for case 1. If you see a question stem featuring a tibial fracture, severe pain out of proportion, pain on passive stretch, a tense swollen limb, but with palpable pulses, that instantly equals acute compartment syndrome. And your very next step is an immediate fasciotomy. Lock that equation right into your memory. Let's transition seamlessly right into case 2, open fractures. We're going to focus heavily on the highly tested Gustilo-Anderson classification. All right, next clinical scenario. A 30-year-old man arrives after a road traffic accident. He's got a deep laceration over his right leg, the bone is literally protruding through the wound, and there's active bleeding. Pulses are palpable. The X-ray quickly confirms an open tibial shaft fracture. So the examiner is definitely going to ask you, what is your absolute first priority in management? Did you jump straight to fixing the fracture? Because that's the trap. Your very first priority every single time is ATLS, airway, breathing, circulation, disability, exposure. You absolutely must manage the patient first, secure their life, and only then manage the limb. Never, ever let a bloody, protruding bone distract you from a compromised airway. Once the patient is actually stable, we evaluate that fracture using the Gustilo-Anderson classification. This is incredibly high yield. Type 1 is a clean wound under 1 centimeter. Type 2 is 1 to 10 centimeters with moderate soft tissue injury. Type 3 is where things get really severe, over 10 centimeters. But I really want to draw your attention to type 3C down at the bottom. Type 3C doesn't just mean it's a massive contaminated wound. It specifically means there is an open fracture with an arterial injury that requires vascular repair. That specific definition is a massive favorite for exam questions. Now, how are we managing the fracture itself down in the ER? You want to follow these steps exactly. Cover the wound with a sterile, saline-soaked dressing. Splint the limb. Administer IV broad-spectrum antibiotics, ideally within 1 hour of arrival. Give tetanus prophylaxis, and then arrange for urgent surgical irrigation and debridement in the OR. I literally cannot stress this enough. Do not repeatedly explore or wash that wound in the emergency department. Let's expose a few more of those sneaky examiner tricks. A common trap might suggest closing the wound in the ER, or maybe waiting to give antibiotics until after surgery. The exam reality? Never, ever close an open fracture in the ER. Cover it with a sterile dressing and get them up to the OR for proper debridement. And those IV antibiotics? Give them immediately. Delaying antibiotics dramatically increases the risk of osteomyelitis, which is by far the most common complication of open fractures. So here is your actionable one-liner takeaway for case 2. Bone visible through a wound equals an open fracture. Your sequence is ABCD first, followed by IV antibiotics, tetanus, a sterile dressing, and a splint, all leading straight to urgent surgical debridement and stabilization. Simple, sequential, and safe. Okay, moving right along to case 3, fat embolism syndrome. This is a really sneaky complication that strikes days after the initial trauma, which makes it a huge favorite for written papers and vivas alike. Let's check out the scenario. A 26-year-old man is admitted with a closed fracture of the shaft of the femur. Initially, he's totally stable, but notice the timeline here. 36 hours later, he develops sudden shortness of breath, confusion, hypoxia with his oxygen sats dropping to 84%, and he's got multiple petechial rashes popping up all over his chest and axillae. What's the diagnosis here? Well, this is the textbook presentation of fat embolism syndrome, or FES, and the absolute most commonly tested cause of FES in the IMM exam is exactly what we just read, a femoral shaft fracture. To diagnose FES clinically, you are hunting for this classic triad: respiratory distress, specifically hypoxemia, neurological symptoms like sudden confusion or agitation, and that highly characteristic petechial rash. These make up Gerd and Wilson's clinical criteria. Oh, and if they happen to ask you about a chest X-ray finding in these patients, look for the classic diffuse bilateral fluffy infiltrates, which is often described as a snowstorm appearance. Now, this brings us to a massive point of confusion for so many candidates. Examiners will actively try to trick you by suggesting FES occurs immediately after the trauma, or they'll say a CT angiogram is the gold standard to confirm it. But the reality? FES characteristically develops 24 to 72 hours later. Furthermore, there is no single gold standard diagnostic test. The diagnosis is entirely clinical. And the treatment? It's purely supportive with high-flow oxygen and ventilatory support if they need it. There's no magic drug to cure this. So, your foolproof equation for instant recognition goes like this: a femoral shaft fracture plus a delay of 24 to 72 hours plus hypoxia, confusion, and a petechial rash equals fat embolism syndrome. Burn that into your brain for exam day. We've covered some incredible ground today. Let's move to our final section, high-yield exam pearls. We'll do a rapid-fire review to consolidate everything you just learned.
Okay, here are your absolute golden rules. Number 1, palpable distal pulses absolutely do not rule out acute compartment syndrome. Pain on passive stretch is your ultimate red flag. 2, ATLS always precedes fracture care. Manage that airway before you even look at the bone. 3, Gustilo type 3 IC specifically denotes an arterial injury that requires vascular repair. And 4, fat embolism syndrome does not strike immediately. It hits 24 to 72 hours post-injury. Keeping these 4 facts straight will save you on so many multiple choice questions.
All right, starting with case 4, the trapped patient, which covers crush syndrome.
Okay, picture this clinical scenario. You've got a 35-year-old guy who is finally rescued after being trapped under a collapsed building for 8 solid hours. Both of his legs were pinned under heavy concrete. Now, post-rescue, he's got severe leg pain and these swollen, incredibly tense calves. Crucially, his urine is dark, we're talking tea-colored, and his overall urine output is dropping. He's tachycardic, and here's the really terrifying part: his ECG is showing tall, peaked T waves.
So, before I just give it away, based on that history of prolonged compression and that massive glowing red flag about the tall, peaked T waves, what exactly are we dealing with here?
You probably nailed it. This is crush syndrome, also known as traumatic rhabdomyolysis. The pathophysiology here is both fascinating and incredibly deadly. Basically, that prolonged compression causes muscle necrosis. And when that muscle breaks down, it dumps a massive load of myoglobin, phosphate, creatine kinase, and, most dangerously, potassium straight into the patient's circulation. That sudden potassium spike, that's exactly what's causing those tall peaked T waves, and it puts the patient at a huge risk for a fatal cardiac arrhythmia. So for your initial investigations, you need to check serum electrolytes immediately. But your gold standard lab marker to confirm the actual extent of that muscle destruction is a markedly elevated serum creatine kinase, or CK.
To save this guy's life and his kidneys, you have to be aggressive and sequence your management perfectly. Step 1 is always your ATLS protocols, right? A, B, C, D, E. But step 2 is a real game changer: aggressive IV isotonic fluids. In a perfect world, you're actually starting those fluids before the trapped limb is even released from the rubble. Next up, treat that hyperkalemia immediately to prevent sudden cardiac death. Then, get a urinary catheter in there to monitor output, because all that myoglobin is going to try its hardest to shut down the kidneys and cause acute tubular necrosis. Now, let's talk about how the examiners are going to try to trick you, because they absolutely love setting traps. First, they'll suggest that dark urine means hematuria. It doesn't. It's myoglobinuria. Second, they might say hyperkalemia is a late complication. Total trap. It develops early and is actually the leading cause of early death here. And the biggest trap of all? Telling you that every crush injury needs a fasciotomy. Do not fall for it. You only take a knife to the patient and perform a fasciotomy if compartment syndrome actually coexists. Crush syndrome needs IV fluids, compartment syndrome needs the knife.
Let's rapidly compare these two. Just to be crystal clear, compartment syndrome is a strictly local problem. It's about raised pressure in a closed space, treated with an emergency fasciotomy. Crush syndrome, on the other hand, is a massive systemic problem of muscle destruction and rhabdomyolysis, treated with aggressive IV fluids and sometimes dialysis. Grasping the difference between systemic muscle destruction and local pressure buildup is an absolute favorite for the IMM exams.
So lock this one-liner into your memory for exam day. A crushed limb plus tea-colored urine, hyperkalemia, and a very high CK equals crush syndrome. And that diagnosis demands immediate, aggressive IV fluids to fight off fatal hyperkalemia and acute kidney injury.
Moving on to our next patient, Case 5, the hot joint, covering septic arthritis.
All right, here's your clinical scenario. We've got a 62-year-old man with diabetes mellitus. He comes in with sudden onset, incredibly severe pain and swelling in his right knee that's been going on for 2 days. He's spiking a fever of 39 degrees Celsius. On exam, the knee is blazing hot, swollen, erythematous, and exquisitely tender. And the absolute key here, he is completely unable to bear weight, and both his active and passive movements are severely restricted.
So, an elderly, immunocompromised, diabetic patient with a blazing hot, swollen, painful joint and a fever. What do you literally have to assume this is, until proven otherwise?
You're looking at septic arthritis of the knee. The most common culprit here, especially in adults, is Staphylococcus aureus. And your definitive proof? That comes from our gold standard investigation, a synovial fluid culture obtained via an urgent joint aspiration. Blood cultures are great and all, but pulling that fluid straight from the joint and sending it off for gram stain, culture, cell count, and crystal analysis, that is how you definitively nail down the diagnosis.
So let's build your management plan. Rule number 1, do not delay. The algorithm is to admit the patient and urgently aspirate the joint. If it doesn't cause a major delay in care, you really want to do this aspiration before you start any antibiotics to get the absolute best culture yield. Once you've got the fluid, hit them with empirical IV antibiotics, get them some analgesia, and immobilize that joint for now. The definitive treatment, though, is joint drainage, usually an arthroscopic or open washout paired with culture-directed IV antibiotics.
Now beware of the MCQ traps on this one. Examiners will try to lull you into a false sense of security by saying the early X-ray is normal. That means absolutely nothing. Early X-rays in septic arthritis are totally normal all the time. They might also throw in a high serum uric acid to make you think, oh, it's just gout. But remember, high uric acid doesn't confirm gout, and it certainly doesn't rule out a joint infection. Only a joint aspiration can truly differentiate this from a gout flare. Oh, and one more massive red flag. Do not ever, under any circumstances, inject steroids into a suspected infected joint.
Let's quickly break down that classic battle, septic arthritis versus acute gout. You need to know this contrast cold. Septic arthritis gives you pus and positive cultures for bugs like Staph aureus, and it absolutely requires IV antibiotics and drainage. Gout, on the other hand, gives you those classic needle-shaped, negatively birefringent monosodium urate crystals, and you treat that with NSAIDs or colchicine. Never mix these two up.
Here is your golden one-liner to take away. An acute, hot, swollen knee plus fever plus a total inability to bear weight equals septic arthritis until proven otherwise. It needs a needle in it immediately, followed by IV antibiotics and a washout.
Let's look at our final patient today. Case 6, the painful tibia, which is acute osteomyelitis.
Take a look at this scenario. A 10-year-old boy is brought into the ED. He's got a high-grade fever and severe pain in his left leg that's been going on for 3 days, and he refuses to walk. On your exam, you find localized tenderness, warmth, and swelling right over the upper tibia. But notice this massive, huge clue. Movement of his knee is relatively preserved, even though it hurts him. Blood work shows marked leukocytosis and spiking inflammatory markers, specifically a really high ESR and CRP.
So think about it. When the bone itself is practically screaming in pain, but the adjacent joint still moves reasonably well, what underlying pathology are you suspecting?
You've got it. This is acute hematogenous osteomyelitis. And what's really interesting here is the location. It typically seeds in the metaphysis of long bones, like the proximal tibia or distal femur. Why? Because the metaphysis has a really rich but sluggish blood supply. It's basically the perfect settling ground for bacteria. Just like our last case, the most common organism across all age groups is Staphylococcus aureus. But here's an exam pearl. If they mention the patient has sickle cell disease, you need to immediately pivot and think of Salmonella species. As for investigations, plain X-rays might be totally normal for the first week, so your gold standard imaging is an MRI. Now, if they ask for the gold standard for the microbiological diagnosis, that's going to be a bone biopsy or bone culture.
When you're evaluating the complications of this disease, especially if it turns chronic, you have to distinguish between two terms that exams love to test: sequestrum and involucrum. The sequestrum is the dead piece of infected bone that is actually separated from the viable bone. The involucrum is the fresh, new bone formed by the periosteum that is trying to wall off that dead piece. For initial management, you admit the patient, draw blood cultures, start empirical IV antibiotics, and immobilize the limb. The definitive treatment is culture-directed IV antibiotics for a solid 4 to 6 weeks. You only go in for surgery if there's an abscess, a sequestrum, or if the antibiotics just aren't working. Because osteomyelitis and septic arthritis often look so similar clinically, fever, pain, and they even share the same offending bug, Staph aureus, this side-by-side contrast is your ultimate defense against tricky viva questions. Osteomyelitis is an infection of the bone metaphysis, best seen on MRI and diagnosed via bone culture. Septic arthritis is an infection of the joint space itself, diagnosed via synovial fluid culture.
We'll leave you with this vital exam memory trick. If the bone is infected, it's osteomyelitis, and you need an MRI. If the joint is infected, it's septic arthritis, and you must aspirate it.
Let's kick things off with Section 1, Fracture Neck of Femur.
Picture this classic vignette. You've got a 78-year-old woman who slips in her bathroom and lands on her left side. She literally cannot stand or bear any weight. When you examine her, you notice her left lower limb is distinctly shortened and externally rotated. Plus, she's got severe growing tenderness, and honestly, any hip movement is just agonizing.
So put yourself in the exam seat for a second. Based on that textbook clinical presentation, what's our most likely diagnosis?
Yep, it's a displaced intracapsular fracture of the neck of the femur. Now, this is overwhelmingly caused by a low-energy fall, usually in an elderly patient with osteoporosis. But hey, quick pearl here. If you see this exact same fracture in a young patient, your mind should immediately jump to high-energy trauma. Think a major motor vehicle accident, right?
Let's unpack the core workup. That shortened, externally rotated limb, that's your massive clinical red flag. Now, for the gold standard initial investigation, you're going to order an epipelvis and lateral x-ray. But watch out, because examiners love this trap. If that x-ray comes back totally normal, but the patient still cannot bear weight, you have to order an MRI of the hip to catch occult fractures. Oh, and absolutely crucial for your Viva questions. The medial circumflex femoral artery is the key blood supply to the femoral head. Burn that into your memory.
Moving into the management algorithm, we classify these using the Garden classification. Remember, Garden 3 and 4 are completely displaced. And why does that displacement matter so much? Because an intracapsular fracture shreds that medial circumflex artery we just talked about, which skyrockets the risk of avascular necrosis, or AVN. So for your younger patients, under 60, you're doing an urgent reduction in internal fixation. But for the elderly, because of that AVN risk, the algorithm skips straight to a hemiarthroplasty or a total hip replacement if they're quite active.
Here's a brilliantly simple memory trick to lock this all in. Inside the capsule equals ischemia. If it's an intracapsular fracture, your brain should immediately go to compromised blood supply, AVN, and a one-way ticket to arthroplasty for your elderly patients.
All right, on to Section 2, Intratrochanteric Femur Fracture.
Here's our next vignette. You have an 80-year-old woman who falls at home, presenting with severe left hip pain. Again, her leg is shortened and externally rotated, literally clinically identical to our first patient. However, this time the X-ray shows the fracture is actually located down between the greater and lesser trochanters. So, here's a defining question examiners love to throw at you. Even though she looks exactly like the first patient clinically, why on earth is the risk of avascular necrosis surprisingly low in this specific scenario?
Well, it's because we're dealing with an extracapsular fracture. It's occurring entirely outside the hip capsule. This means that critical blood supply to the femoral head is actually perfectly preserved. And that, my friends, completely flips our treatment approach.
Let's compare them side by side to really clarify this. A neck of femur fracture is intracapsular, blood supply is compromised, AVN risk is super high, so we do an arthroplasty in the elderly. On the flip side, an intertrochantic fracture is extracapsular, blood supply is preserved, and the AVN risk is low. So instead of throwing away the joint, we fix it. We use internal fixation, like a dynamic hip screw or maybe a proximal femoral nail if it's unstable.
To make sure you never mix these two up under exam pressure, here's another great memory trick. Neck equals new joint. Trochanter equals tighten with screws. I mean, how perfectly does that capture the surgical philosophy for both? Okay, keeping the momentum going, Section 3, supracondylar fracture of humerus. Our next clinical picture is a major pediatric orthopedic emergency. We've got a 7-year-old boy who takes a fall on an outstretched hand, a classic Fouche injury. His elbow is massively swollen and deformed, but here is the massive red flag. His hand is warm, but his radial pulse is remarkably weak, and any finger movements are highly painful. So, we need to answer two things based on this presentation. First, what is the specific diagnosis? And second, which nerve is most commonly injured in this exact scenario? The diagnosis is an extension-type supracondylar fracture of the humerus. Now, interestingly, the nerve most commonly injured here is the anterior interosseous nerve, or the AIN, which is a branch of the median nerve. A lot of people guess ulnar or radial, but no, it's the AIN. Alongside that nerve, you absolutely have to worry about the brachial artery. When you get the X-ray, keep an eye out for the posterior fat pad sign. That's a huge hint for an occult fracture. We classify these using the Gartland system, and for the displaced ones, your definitive treatment is CRPP, closed reduction and percutaneous pinning. Now, why are we obsessing over that weak pulse? Because if you miss compartment syndrome or a brachial artery injury, it can lead to the dreaded Volkmann's ischemic contracture, and you definitely do not want that.
The ultimate takeaway mnemonic for this one? Supracondylar equals save the pulse. It's a fantastic reminder that checking your neurovascular status before and after reduction isn't just important, it's paramount.
All right, let's bring it all home with Section 4, high-yield exam pearls.
Let's aggressively debunk some common MCQ traps that examiners love to set. First trap, the statement, every neck of femur fracture is fixed with screws. Absolutely false. As we know, displaced fractures in the elderly require arthroplasty. Second trap, a normal pulse totally excludes vascular injury in the elbow. Again, false. Arterial spasm or an occult injury could totally still be lurking there. And third trap, the ulnar nerve is the most commonly injured in an extension Fouche elbow. Wrong again. As we just saw, it is the anterior interosseous nerve. Don't fall for these.
To wrap up today's explainer, let's cement these ultimate one-liners. A shortened externally rotated leg? Think hip fracture. A displaced intracapsular neck of femur in an elderly patient? That's going to be a hemiarthroplasty. An intertrochanteric fracture? That's extracapsular. Grab the DHS or PFN. And a kid with a Fouche injury and a massively swollen elbow? You better be checking that brachial artery.
Okay, let's dive right into this. Section 1, Case 1, the unstable pelvic fracture. Picture this. We've got a 35-year-old guy rushed into the ED after a high-speed road traffic accident. He's confused, he's pale, and he's sweating profusely. Now look at these vitals. His blood pressure is absolutely tanking at 80/50, and his pulse is racing at 132 beats per minute. On examination, you note obvious pelvic instability, and crucially, pay attention to this, there is blood at the external urethral meatus. So, based on that specific presentation, what is your most likely diagnosis? I'm going to give you a second to lock your answer in. But remember, don't just say broken pelvis. You got to think like a surgeon here. Well, if you said unstable pelvic fracture with hemorrhagic shock, you absolutely nailed it. See, the examiner's primary concern in this scenario isn't actually the broken bones themselves. It's the massive hemorrhage.
Here's a fun anatomical fact. The retroperitoneal space can literally hide up to 4 liters of blood, and that is exactly why these patients can exsanguinate incredibly fast without you ever seeing a single drop externally. So, remember this golden rule for the exam. A patient with a pelvic fracture and shock is bleeding until proven otherwise. Hemorrhagic shock is the most common cause of death here. You simply cannot focus on fixing the fracture before you stabilize that hemodynamic collapse. Let's walk through the actual life-saving management algorithm. Step 1 is always your ATLS protocols, the ABCDEs. Step 2, and this is your immediate priority for the pelvis itself, is applying a pelvic binder. Step 3, get that AP pelvic X-ray as part of your trauma survey. And Step 4, perform a retrograde urethrogram or RUG. Now, you absolutely must do the RUG before you even think about inserting a Fuller catheter, all because of that blood at the meatus. That's a huge red flag signaling a suspected urethral injury. Now, what's really interesting about this slide is how examiners literally love to set traps here. The most common trap? Telling you to apply the pelvic binder over the iliac crests. No way. The reality is that it must go over the greater trochanters to actually close the pelvic volume effectively. Another massive trap? Inserting a Foley catheter immediately in all trauma patients. The reality? Never do that if there's blood at the meatus. You need that URG first. Seriously, do not fall for these. Just anchor this entire case with this one simple memory trick. Pelvis equals pressure. If the patient has an unstable pelvic fracture, you need pressure from a pelvic binder to close the ring, and pressure support with blood products to reverse the hemorrhagic shock. You have to control the bleeding with pressure before you ever worry about fixing the bones. All right, let's transition smoothly right into our next topic. Section 2. Case 2. Spinal cord injury. Here is the scenario we're dealing with now. A 30-year-old male is brought in after falling from about a 15-foot height. He's on a spinal board, he complains of neck pain, and he has this flaccid paralysis of both legs with completely absent lower limb reflexes. Now pay very close attention to these vital signs. His blood pressure is 85/60, but his pulse is just 48 beats per minute. So, based on that mechanism of injury, the paralysis, and those very specific, frankly alarming vital signs, what is the most likely diagnosis? Let's test your clinical pattern recognition right now. The answer is acute spinal cord injury with neurogenic shock. Guys, this is a massive examiner differentiation point. The clinical pearl here is that hypotension combined with bradycardia after spinal trauma absolutely screams neurogenic shock. It happens because the injury disrupts the sympathetic pathways in the spinal cord, which basically leaves the parasympathetic system completely unopposed. And this brilliantly illustrates exactly what examiners love to test. Can you distinguish neurogenic shock from hemorrhagic shock? Look, they both feature low blood pressure, right? But in hemorrhagic shock, the body is trying to compensate for blood loss. So you get tachycardia, a super fast heart rate, and cold, clammy skin. In neurogenic shock, because of that loss of sympathetic tone we just talked about, you get bradycardia, a very slow heart rate, and the skin is actually often warm and dry. So what's our immediate management? Step 1, cervical spine immobilization. Every single trauma patient has a C-spine injury until proven otherwise. Step 2, a CT scan of the entire spine. That's your best initial imaging in major trauma. Step 3, if there are neurological deficits, an MRI is required to properly assess the cord. And Step 4, treat the shock with IV fluids and vasopressors. But take note of this, no routine steroids. Actually, scratch that, it's more like never use them routinely anymore. Modern guidelines have shifted drastically. Routine high-dose methylprednisolone is simply no longer recommended because the risks totally outweigh the benefits. That is a huge exam update you need to know. Drive this one-liner home so you never, ever fall for the hemorrhagic shock trap on exam day. Low BP plus low pulse after spinal trauma equals neurogenic shock. The second you see that low heart rate on the test, stop thinking about massive bleeding for a second and start thinking about the sympathetic nervous system. Moving on to our final surgical emergency, Section 3. Case 3, cauda equina syndrome. So we have a 45-year-old man presenting with severe low back pain that's radiating down both of his legs for the last 2 days. But today, things escalated really fast. He developed an absolute inability to pass urine, urinary retention, and he's noticing numbness right around the perineum. On exam, he has reduced anal tone and absent angle reflexes. Guys, this is no longer just a routine backache. This is a full-blown crisis. Given this classic, honestly terrifying constellation of severe neurological symptoms, what is your diagnosis?
Yep, this is cauda equina syndrome, or CES. It is an absolute orthopedic and neurosurgical emergency. And as for the most common cause, it's a massive central lumbar disc prolapse, usually sitting right at L4-L5 or L5-S1, completely compressing those nerve roots. Remember, this is a structural compressive emergency. It's not just some localized inflammation. You absolutely must have these red flag symptoms memorized instantly. Severe back pain, bilateral sciatica, saddle anesthesia, urinary retention, and fecal incontinence. And out of all of these, urinary retention is by far the most critical red flag to watch out for. Literally, if a patient with back pain suddenly tells you they can't pee, massive alarm bells should be ringing in your head.
The management algorithm here is a literal race against the clock. Step 1, suspect it clinically. Step 2, get an urgent MRI of the lumbosacral spine. An MRI is both the initial investigation of choice and the absolute gold standard here. Step 3, immediate neurosurgical or orthopedic referral. Step 4, emergency surgical decompression, which is ideally a lumbar laminectomy with discectomy, and it needs to happen within 24 to 48 hours. For sure, the single most important prognostic factor for these patients is the time to surgery.
Now, examiners love to make you differentiate cauda equina syndrome from conus medullaris syndrome. It's a classic trick. Anatomically, CES affects the peripheral nerve roots, which presents with severe asymmetric bilateral sciatica and early urinary retention. Conus medullaris syndrome, on the other hand, affects the terminal spinal cord itself. That presents with generally less severe pain, but you get symmetrical, very early bladder and bowel dysfunction, along with mixed upper and lower motor neuron signs. Here is your final memory one-liner for today, and I want this one to stick with you forever. Can't pee plus can't feel the saddle equals cauda equina until proven otherwise. Seriously, if you see urinary retention and saddle anesthesia, do not pass go. Do not try conservative physiotherapy. Get an urgent MRI and prep the OR.
Imagine a 25-year-old guy walks into your ER after a nasty fall playing cricket. You look at him and his arm is just stuck, abducted and externally rotated. You check the shoulder contour and it's completely squared off where that nice round deltoid prominence should be. Plus, he's complaining his lateral shoulder is numb. So based on those exact clinical features, what's your immediate diagnosis?
If you immediately thought anterior shoulder dislocation, you hit the nail on the head. This is, without a doubt, the single most common major joint dislocation you're going to see. We're talking a massive 95% of all shoulder dislocations.
Now, there is absolute exam gold packed in here.
The classic mechanism? Forced abduction, extension, and external rotation. But here's what the examiners are really obsessed with: the axillary nerve injury. You've got to look for that classic numbness right over the lateral shoulder, the regimental badge area. And when it comes to imaging, there's a strict, non-negotiable rule. You absolutely must get AP, scapular Y, and axillary x-rays before you even think about attempting a reduction. Oh, and keep an eye out for associated lesions, specifically the Bankart lesion, which is an anterior-inferior labral tear, and the Hill-Sachs lesion, a compression fracture of the humeral head.
So how do we actually manage this? It's not just about yanking the joint back into place. Step 1 is proper analgesia and sedation. Step 2, and this is literally crucial, you must assess and document the neurovascular status. Only then do you move to step 3, the closed reduction. Once it's back in, step 4, repeat that neurovascular exam. Finally, get a post-reduction x-ray and pop that arm in a sling. Now, definitive treatment down the line is usually just physio, but if they keep dislocating it, surgical Bankart repair is the way to go.
Okay, listen closely, because this is exactly where MCQs are going to try to trap you. They'll try to tell you the radial nerve is the most commonly injured here, or they'll bait you into saying you should reduce the shoulder immediately to relieve pain before checking nerves. Total trap. The reality? The axillary nerve is the star of this show, and you must always, always document that neurovascular status before and after reduction to prove you didn't cause the damage yourself during the maneuver.
To lock this in, just remember this simple trick. If the arm is abducted and externally rotated, think arm out for anterior dislocation. And the second you think arm out, your brain needs to immediately jump to the examiner's 3 favorite follow-ups: the axillary nerve, the Bankart lesion, and the Hill-Sachs lesion. Moving right along to case 2, the Monteggia fracture. Let's drop down from the shoulder to the forearm for an emergency they absolutely love to test.
Picture this scenario. A 30-year-old guy comes into the ER after flying off his motorcycle and landing on an outstretched hand. Your classic foosh injury. He's got a ton of swelling over the upper ulna, and he basically can't move his elbow. You get the x-rays, and boom, you see a fracture of the proximal ulna accompanied by a dislocation of the radial head. What's your immediate diagnosis?
If you said Monteggia fracture dislocation, you're right on the money. This is a highly tested, classic injury pattern where the proximal third of the ulna snaps and the energy travels up and pops the radial head right out of its joint.
Let's break down why this is so tricky. The absolute golden rule for investigations here is you have to x-ray the joint above and the joint below. Just grabbing a forearm x-ray isn't going to cut it. You need the elbow and the wrist to actually catch that sneaky radial head dislocation. Complication-wise, you are on high alert for a posterior interosseous nerve, or PIN, palsy. That's a motor branch of the radial nerve, so your patient will suddenly lose the ability to extend their fingers or thumb, but usually they won't have any sensory loss. And just for those sweet bonus viva points, remember the Bedeau classification. Type I, the anterior dislocation, is the one you'll see most often.
When it comes to treating this in adults, make no mistake, this is a surgical disease. You've got to fix the ulna with an open reduction and internal fixation, or RF. And here's the really cool part about this surgery. Once you anatomically restore the length of that ulna with a plate, the radial head almost magically snaps back into place completely on its own. Just remember to check that pin function again post-op.
Don't fall for the classic MCQ trap here. Examiners love to confuse the bones. They'll claim a Monteggia fracture involves the radius, or they'll try to convince you that you can just cast it in an adult. No way. The reality is the primary fracture is in the ulna, and ORIF is the absolute gold standard for adults.
Anchor this in your brain right now with a classic mnemonic UMGR. The M and U mean Monteggia equals ulna fracture plus the radial head dislocation. Say it a few times. MUGR. It is a literal lifesaver on exam day.
All right, case 3, the Galeazzi fracture. This one is practically glued to the Monteggia fracture on exams, just to see if you can tell them apart.
Now we're moving down the arm to the wrist. A 32-year-old man comes in with another FOSH injury, but this time the swelling and deformity are down over the distal radius. You check the x-rays and there's a distal third radius fracture alongside a dislocation of the distal radio-ulnar joint, the DRUJ. What is the name of this specific pattern?
Yep, that is the Galeazzi fracture dislocation. It's a notoriously unstable injury where the radius breaks lower down and the distal radial ulnar joint just completely blows out. Because this injury is so wildly unstable, it has a very famous, highly tested nickname, the fracture of necessity. You know why? Because non-operative treatment in adults almost always fails. The pull of the forearm muscles will literally cause the fracture to collapse. So, surgical ORIF of the radius with plate fixation is absolutely necessary. Clinically, you're going to see a prominent ulnar head, and the patient will have agonizing pain on pronation or supination because of that DRUJ instability. And post-op, you've got to double-check that DRUJ. Sometimes it's still unstable even after plating the radius, and you'll need to throw in a temporary K-wire.
Once again, watch out for the bone-swapping traps. They'll say Galeazzi involves the ulna, or they'll suggest you can just treat an adult conservatively with a cast. Wrong again. The fracture is in the radius, and because it is a fracture of necessity, ORIF is the only way to go.
So, what's the ultimate memory trick to pair with Muger? It's GRUD. The G and R stand for Galeazzi equals radius fracture, and the U and D remind you of the ulnar or DRUJ dislocation. Muger and GRUD. Keep those two words in your back pocket for sure.
Section 4. Forearm showdown and pearls. Putting these concepts side by side is an absolute favorite for oral boards.
Let's put them head to head so you never mix them up. Monteggia is your proximal ulna fracture with a radial head dislocation up near the elbow. It risks the pin nerve, and you treat it by fixing the ulna. Galeazzi, on the other hand, is your distal radius fracture with a DRUG dislocation down by the wrist, and you treat it by fixing the radius. Between this showdown and your MUGR and GRUD mnemonics, you are completely bulletproof on these.
All right, picture this. You're sitting in the exam hall, and you're hit with this vignette. A 42-year-old guy is out playing badminton. Out of nowhere, he feels this intense, sharp pain in the back of his ankle. In fact, he swears it felt exactly like someone kicked him from behind. But nobody's there. He can't stand on his toes, and when you examine him, there's a distinct 4-centimeter palpable gap just above the heel. So, what's the most likely diagnosis? Take a second and lock in your answer.
Yep, it's an acute,
Achilles tendon rupture. Now, the classic profile here, it's your middle-aged weekend warrior. The mechanism we see over and over is a sudden, forced dorsiflexion of the ankle or an explosive push-off when they're running or jumping.
Let's unpack the really high-yield clinical features here. These patients will often tell you they actually heard a sudden snap or pop. They absolutely cannot stand on tiptoes, and here's a crazy stat. Up to 25% of these are completely missed in the ER on the very first visit. So you really have to master the clinical signs. The absolute holy grail for your exam is the Thompson test, also called the Simmons test. Normally, if you squeeze the calf, the foot should plant or flex, right? If it doesn't, boom, positive test. Anatomically, this rupture almost always happens right in that poorly vascularized watershed area, about 2 to 6 centimeters proximal to the calcaneal insertion. Oh, and watch out for the risk factors. If the exam stem drops a hint about fluoroquinolone antibiotics or recent corticosteroid use, your clinical suspicion should immediately go through the roof.
Now, let's talk investigations, because this is a massive MCQ trap. Examiners love to bait you into ordering high-tech imaging right out of the gate. But what's the actual best initial investigation? It's a solid hands-on clinical examination. A positive Thompson test is usually all you need to make the call. But if the case is a bit murky or the surgeon is trying to map out the operation, that's when you bring in the MRI. MRI is your gold standard, but please do not let them trick you into picking it as step 1 for a totally obvious presentation.
So how do we fix it? Well, definitive treatment is strictly dictated by the patient's age and how active they are. That's step 1, assess their demand. Step 2, if you've got an older, low-demand patient, you're looking at functional bracing or casting, keeping that ankle nicely in plantar flexion. But step 3, for your young, highly active athletes, or if it's a really severe complete rupture, surgical tendon repair is the way to go. Just remember, the conservative route does carry a higher risk of re-rupture, which happens to be the most common complication across the board. Now, what's really interesting here is how clearly we can differentiate an Achilles rupture from a severe ankle sprain. This is a huge Viva trap, so let's break it down. Think about the mechanism. It's a sudden push-off versus a typical inversion injury. The pain in an Achilles rupture is dead center posterior, whereas a sprain is almost always lateral. Thompson test, positive in a rupture, completely negative in a sprain. Plus, a patient with a sprain can usually still manage to stand on their tiptoes. Sure, it'll hurt, but they can do it. And of course, they won't have that classic palpable gap.
To really lock this into your brain, just remember this simple one-liner. Pop behind the ankle equals think Achilles. If you've got a middle-aged athlete who feels like they got kicked from behind and they've got a positive Thompson test, you literally know exactly what you're dealing with.
All right, moving on to section 2, anterior cruciate ligament injury.
Let's hit our next rapid-fire clinical case. You've got a 24-year-old football player making a rapid change of direction. He twists his right knee. And notice this, there is zero contact from another player. He hears a loud pop, goes down immediately, and he's totally done for the game. But here's the absolutely critical detail. Within just 2 hours, his knee blows up like a balloon, markedly swollen. So what are we thinking for the diagnosis?
You guessed it. That is an anterior cruciate ligament, or ACL, rupture. The golden rule for your exams here is incredibly straightforward. A pop combined with immediate hemarthrosis equals an ACL tear until proven otherwise. The classic mechanism is always that non-contact twisting injury coupled with sudden deceleration.
Let's sift out the clinical buzzwords. You are hunting for that audible pop, the instant pain, and the incredibly rapid knee swelling. That swelling is hemarthrosis, meaning the joint is actually bleeding. Patients will also tell you their knee just feels totally unstable, like it's simply giving way under them. When you're at the bedside, the absolute best, most sensitive clinical test, and the one examiners want to hear, is the Lachman test. It beats out the anterior drawer test every time, especially right after the acute injury. And one last thing, associated meniscal tears, especially the lateral meniscus in these scenarios, are super common.
And speaking of associated injuries, this brilliantly illustrates the classic unhappy triad. Examiners love to test your anatomical pattern recognition with this one. It's a devastating combo: a tear of the ACL, a tear of the medial collateral ligament, and a tear of the medial meniscus. Definitely commit this triad to memory.
All right, back to investigations. This is another trap where students just throw away easy marks. Because MRI gives such beautiful soft tissue detail, it's so tempting to choose it first. Don't do it. Your best initial investigation has to be a plain X-ray. It is absolutely mandatory to exclude any fractures first. Once you're clear of fractures, then you go ahead with the MRI of the knee.
That's your gold standard to confirm the ACL tear and check out any cartilage or meniscal damage.
Under exam pressure, it's remarkably easy to mix up the anterior and posterior cruciate ligaments. So let's use this to keep things straight. The ACL goes down from twisting and pivoting. The PCL, that's your classic dashboard injury, or taking a hard fall directly onto a flexed knee. ACL damage means anterior tibial translation, which we catch with the Lachman test. PCL means posterior translation, caught by the posterior drawer test. And remember our golden rule? Immediate hemarthrosis is classic for the ACL, but for the PCL, swelling is actually pretty variable.
So here's a quick mnemonic to anchor the ACL presentation. ACL equals athlete changes direction, and here's a loud pop. You see a young athlete, a twisting injury, a pop, massive rapid swelling, and a positive Lachman. Your definitive treatment for that active patient is going to be ACL reconstruction using a tendon graft.
Okay, let's roll into Section 3, medial meniscal tear. Here's our final clinical scenario. We have a 30-year-old footballer who violently twists his right knee while his foot is firmly planted. But pay close attention to the difference in this stem. His knee swelling is delayed. It creeps in slowly over the next 24 hours. He's also complaining that his knee keeps locking up when he tries to walk. You examine him, and boom, a positive McMurray's test. What's the diagnosis this time?
That is a medial meniscal tear. And look, it is absolutely essential to know that the medial meniscus takes a hit way more often than the lateral one. Why is that? Because it's physically anchored right to the medial collateral ligament, the MCL. That makes it way less mobile and significantly more vulnerable when the knee gets twisted.
Let's walk through the exact features. The mechanism here is very specifically a twisting motion on a weight-bearing, flexed knee. Clinically, you're looking for that delayed swelling, taking hours or even a full day to show up. You'll see locking, clicking, and joint line tenderness. The McMurray's test is your classic clinical go-to here. Also, examiners are absolutely obsessed with bucket handle tears. Those are the classic culprit behind a fully locked knee. As for management, if it's a small, stable tear, we play it conservative, rest and NSAIDs. But if those mechanical symptoms just won't quit, or if you're dealing with a large bucket handle tear causing locking, arthroscopic meniscal repair is the definitive move to help prevent early osteoarthritis down the road.
So what's the absolute crucial takeaway here? It's the timeline of the swelling. I cannot stress this enough. This is the ultimate differentiating factor in your exam stems. Immediate swelling, like hemarthrosis blowing up the knee in an hour or two, that screams acute ACL rupture. Delayed swelling that sneaks in over a day or so, that is highly suggestive of an isolated meniscal tear. You absolutely cannot miss this distinction.
This rapid differential perfectly cements exactly what we just talked about. ACL, immediate swelling, massive instability, positive Lachman, and an audible pop. Meniscal tear, delayed swelling, mechanical symptoms like locking or catching, a positive McMurray test, and usually no pop at the exact moment of injury. Sure, MRI is your gold standard investigation for both of them, but clinically, their presentations are night and day.
All right, case 1. Let's start with carpal tunnel syndrome. This is arguably the most frequently tested peripheral nerve entrapment syndrome you'll see on the IMM exam. Picture this, you're the attending, and this case comes across your desk. A 45-year-old female presents with numbness and tingling in her thumb, index, middle, and the radial half of her ring finger. It's been going on for 6 months, but crucially, it's significantly worse at night, and it's literally waking her up. She also tells you her grip feels weak and she's struggling to button her clothes. So I want you to actively recall the answer here. Look at those specific fingers and that nocturnal timing. What is the most likely diagnosis, and exactly which nerve is being compressed? Take a second to lock it in. If you said carpal tunnel syndrome caused by median nerve compression, you are absolutely correct. Now, what's really interesting about this, and a classic MCQ trap examiners will use, is they'll try to tell you the whole hand is numb. But no, the little finger is completely spared because that is ulnar nerve territory. The compression happens right at the wrist, underneath the flexor retinaculum. To confirm this at the bedside, we use Phelan's test. You flex the wrist for 60 seconds to see if it reproduces the symptoms, along with Tinel sign. Remember, if you see thenar muscle wasting, that is a late sign of advanced disease. And for your exam, the absolute gold standard investigation to confirm this is nerve conduction studies, or NCS. Let's look at how we manage this. We don't just rush everyone to the operating room. It's a stepwise approach. Step 1 is conservative. Get them a wrist splint, especially for nighttime use, and start some NSAIDs. If that doesn't do the trick, step 2 is a corticosteroid injection directly into the carpal tunnel. And finally, step 3 is definitive carpal tunnel release surgery. where you go in and divide the flexor retinaculum. Now, pro tip, you jump straight to surgery if the patient already has thenar wasting or severe abnormalities on their nerve conduction studies. You absolutely must know how to distinguish carpal tunnel from its biggest exam distractor, cubital tunnel syndrome. And honestly, anatomy directly dictates the clinical presentation here. Carpal tunnel involves the median nerve at the wrist, sparing the little finger. In contrast, cubital tunnel involves the ulnar nerve getting compressed way up at the elbow, and that directly affects the little finger and causes hypothenar wasting. Keep this anatomical map crystal clear in your head. To lock this in for test day, just memorize this one-liner. 3.5 fingers at night equals carpal tunnel. If the question stem talks about nocturnal tingling in the thumb, index, middle, and half the ring finger, but the pinky is perfectly fine, boom, you've got your diagnosis. Moving right along to case 2, de Quervain's tenosynovitis. Here is our second scenario, and it's a classic outpatient condition that examiners just love. A 32-year-old woman, 3 months postpartum. She comes to your clinic complaining of sharp pain over the radial side of her wrist. The key detail? The pain dramatically worsens every time she lifts her baby out of the crib. You examine her and find marked tenderness directly over the radial styloid. Based on that textbook presentation of a new mother with radial wrist pain, the diagnosis should already be popping into your head. But let's challenge you. What is the hallmark bedside examination test you're going to perform to confirm it? The diagnosis is de Quervain's tenosynovitis, and the test is the Finkelstein test. You have the patient tuck their thumb into their palm, make a fist, and you passively deviate the wrist towards the ulnar side. If they get sharp radial pain, that's a positive. So the crucial point to understand here is the pathology. This is not a nerve compression. It is stenosing tenosynovitis of the first dorsal extensor compartment. You have to memorize the 2 tendons involved, the abductor pollicis long, or APL, and the extensor pollicis brevis, or EPB. And unlike our last case, the best investigation here is purely a clinical diagnosis. No fancy tests needed. For management, we're back to our stepwise algorithm. Step 1 relies on a very specific type of splint, the thumb spica splint, along with activity modification. If conservative therapy fails, step 2 is a corticosteroid injection, which is incredibly effective for this condition. But if symptoms stubbornly persist despite those injections, we proceed to step 3, a surgical release of that first dorsal compartment. And this brilliantly illustrates exactly how examiners will try to twist the symptoms to confuse you. They might casually throw in the word numbness to bait you into choosing carpal tunnel, or say a median nerve issue is causing de Quervain's. Let's compare them directly. De Quervain's is a tendon sheath problem with radial wrist pain, diagnosed via the Finkelstein test. Carpal tunnel is a median nerve problem with sensory numbness, diagnosed via Phelan's test. They are entirely different anatomical systems. Look, if you only remember one thing for this condition, make it this phrase: mother can't lift the baby. If the vignette features a postpartum woman with radial wrist pain triggered by lifting her kid and a positive Finkelstein test, it screams de Quervain's tenosynovitis. Don't overthink it. All right, let's wrap things up with case number 3, trigger finger. This condition is an incredibly popular Viva topic. Consider this vignette. A 55-year-old female with a long history of type 2 diabetes mellitus complains that her right ring finger keeps getting stuck in a flexed position when she grips things. To straighten it out, she literally has to use her other hand, which produces a very painful click or snap. That painful clicking and locking gives away the diagnosis of trigger finger. But here is the high-yield postgraduate exam question for you. What is the exact anatomical site of the pathology causing this? Where precisely is that tendon getting stuck? The exact site of pathology is the A1 pulley. This is stenosing flexor tenosynovitis. The flexor tendon thickens, the A1 pulley narrows, and it prevents smooth gliding. Examiners love to test this by offering the A2 pulley or the palmar fascia as options. Please don't fall for it. On examination, you can actually often feel a tender nodule right over that A1 pulley at the base of the finger. Also, take note of the massive clinical association between trigger finger and diabetes mellitus. And just like de Quervain's, your best investigation is a clinical diagnosis. Treatment starts with activity modification, splinting, and critically, getting that underlying diabetes under control. However, when we talk about definitive treatment, a corticosteroid injection straight into the flexor tendon sheath is actually considered your first-line definitive option here. Most patients respond beautifully to the steroid. It's really only when symptoms keep coming back after injections that we opt for step 3, a surgical A1 pulley release.
Let's move to differential diagnosis skills, because in an oral exam, you are almost certainly going to be asked to differentiate trigger finger from Dupuytren's contracture. So trigger finger is an A1 pulley issue featuring a painful lock or click, but the finger can ultimately be straightened out. Dupuytren's, however, is a fibrosis of the palmar fascia. It's usually totally painless, and it results in a fixed flexion deformity, meaning that finger simply cannot be fully straightened no matter how hard you pull.
Right along to case 2, Ewing sarcoma. This is the second most common primary malignant bone tumor in children, and honestly, an absolute favorite for examiners to test you on.
Let's set the scene for our next clinical scenario. A 12-year-old boy walks in presenting with pain and swelling in the mid-shaft of his right femur. He's also running a low-grade fever and has experienced some recent weight loss. You run some bloods and they show a raised ESR. Then on the X-ray, you clearly see a diaphyseal lytic lesion with an onion skin periosteo reaction. Think about those highly specific, almost weird clues. What is the diagnosis here?
Yep, it's Ewing sarcoma. Now notice the demographic shift here. We're looking at 5 to 20 years old. But the really critical differentiator from our first case is the location. Whenever you see a tumor in the diaphysis of a long bone in a child, especially the femur, you absolutely must think Ewing sarcoma. Just as a fun historical fact, James Ewing actually first described this back in 1921, and he originally thought it was an endothelioma. But today, you just need to know it as the ultimate diaphyseal menace.
Let's rapid fire some classic buzzwords for Ewing so you're ready for test day. On the X-ray, you're hunting for that lamellated, onion skin periosteal reaction. The gold standard is, once again, a core needle biopsy, which on histology is going to reveal these classic, small, round blue cells. Now, what's really interesting about this condition is its genetics. Ewing sarcoma is highly associated with the T1122 translocation. Do not forget that. It's a classic, high-yield exam question. And just like osteosarcoma, the lungs are the most common site of metastasis.
Now, you might be wondering, why on earth did our 12-year-old patient have a fever and a raised ESR? Well, that's because Ewing sarcoma is known as the great mimic. It often looks clinically identical to osteomyelitis, which is a bone infection. But the clinical and visual clues we just went over definitively separate the tumor from the infection. Ewing is a tumor in the diaphysis, it's got that onion skin appearance, and biopsy shows small round blue cells. Osteomyelitis, on the other hand, is an infection that typically hangs out in the metaphysis, usually lacks that onion skin look, and a culture is going to confirm pus and bacteria, not tumor cells.
So how do we treat it? Building right on our previous knowledge, the treatment involves neoadjuvant chemo and wide surgical excision. But crucially, look closely at step 3, radiation. Unlike osteosarcoma, Ewing sarcoma is highly radiosensitive. This makes radiation a remarkably effective tool in your treatment arsenal for this specific tumor, which you then follow up with adjuvant chemotherapy.
Time for your definitive anchor equation for Ewing sarcoma. Child plus fever plus a painful diaphyseal lesion plus an onion skin appearance equals Ewing sarcoma. You follow that with an MRI, a biopsy that's going to show small round blue cells and that T1122 translocation, and finally, you treat with chemotherapy, surgery, and importantly, radiotherapy.
All right, final case. Case 3, giant cell tumor, also known as osteoclastoma. It's benign, but it is locally aggressive. Here's the scenario. A 28-year-old woman presents with progressive pain and swelling around her left knee. An X-ray shows an eccentric, expansile lytic lesion involving the epiphysis, giving a very distinct soap bubble appearance. I've basically handed you the keywords here: 28-year-old, epiphysis, and soap bubble. Take a bait. What's your diagnosis?
Spot on. That is a giant cell tumor. Now, the massive takeaway here is that unlike the other two tumors we just discussed, this one occurs after epiphyseal closure. It strictly targets skeletally mature adults, usually folks between 20 and 40 years old, and it sits exclusively right in the epiphysis of long bones, again, typically right around the knee.
Let's look at the essentials. Your X-ray hallmark is that totally unmistakable soap bubble appearance of an eccentric lytic lesion. In terms of its nature, it's benign, meaning it rarely ever metastasizes. But it is extremely locally aggressive and carries a very high local recurrence rate. The gold standard is a core biopsy showing those multinucleated giant cells. And this brilliantly illustrates how targeted pharmacology works. For unresectable or recurrent cases, we use denosumab, a rank L inhibitor.
It directly reduces that aggressive osteoclast activity, basically telling those bone-eating cells they need to take a mandatory vacation. Because this tumor is actually benign in nature, our whole treatment approach shifts. We don't need the aggressive chemotherapy and wide excision that we saw in our previous malignant tumors. Instead, after a core biopsy confirms the diagnosis, step 2 is an extended curettage, which is essentially just scraping the tumor out of the bone. Step 3 then involves filling that resulting defect with adjuvant therapy like bone cement, which is also known as PMMA, or you could use bone grafting.
Let's anchor this final case into your memory. Young adult, plus an epiphyseal lesion around the knee, plus a soap bubble appearance equals a giant cell tumor. You confirm it with a core biopsy, and you treat it with an extended curettage and some bone cement.
Okay, we made it to the grand finale, the high-yield exam summary, featuring the MED mnemonic. This comparative matrix right here, this is your ultimate cheat code. The crucial point is the MED mnemonic. MED, metaphysis, epiphysis, diaphysis. If the tumor is in the metaphysis, you need to think osteosarcoma, especially if it's a teen with a sunburst X-ray. If it's in the epiphysis, you think giant cell tumor, especially in a 20 to 40-year-old with a soap bubble X-ray. And if it's in the diaphysis, think Ewing sarcoma, especially in a kid with an onion skin X-ray. MED. It is literally that simple, and I promise you it will save you precious time on those multiple choice questions.
I want to leave.
Okay, let's dive right into this with our first patient. Let's start with congenital clubfoot.
Picture this scenario. You're in the pediatric clinic and a 2-week-old baby boy is brought in. His right foot has been turned inwards since birth. Now I want you to pay close attention to this specific phrasing. The deformity is rigid and it literally cannot be manually corrected. The pregnancy was completely uneventful and his neurology is totally normal. I'll pause for just a quick second here. What diagnosis is flashing in your mind right now?
If you instantly thought of congenital talus equinovarus, or CTEV, which we all commonly just call clubfoot, you hit the nail on the head. CTEV is a really complex structural congenital deformity. And when I say structural, I mean it involves literally everything in that foot: the bones, the joints, the muscles, the tendons, the whole shebang. Now, because it's a rigid structural abnormality, the diagnosis is primarily clinical. That means you do not need routine X-rays in newborns to make this call. Your clinical exam is hands down your most powerful tool.
And this brilliantly illustrates exactly what you're hunting for during that exam. It's the famous cave deformity. You know, examiners absolutely love this mnemonic. So, C stands for cavus, which gives you that high medial arch. A is for adduction of the forefoot. V is for varus of the hindfoot. And let me emphasize this, it is varus, not valgus. Please don't let them trick you on the test with that one. Finally, E is for equinus, meaning plantar flexion at the ankle. CAVE. Definitely memorize that, because spotting it leads you directly to the clubfoot diagnosis.
Now here's a massive differentiator you absolutely must know for the exams. True CTEV versus positional clubfoot. Positional clubfoot just happens from the way the baby was sitting in the uterus. It's a flexible deformity. You can easily correct it manually, and it usually resolves on its own with some simple stretching. True CTEV, on the other hand, it is structural and rigid. It cannot be passively corrected, and it absolutely requires definitive, structured intervention. So remember, rigidity is your ultimate dividing line.
So what exactly is that definitive intervention? Well, it's the gold standard Ponzetti method, and this needs to begin within the first few weeks of life. It's an incredibly elegant 4-step process. You start with weekly gentle manipulation, followed by serial plaster casts. Then, if you need to fix the equinus, you perform a percutaneous Achilles tenotomy. Finally, you use a foot abduction brace to maintain the correction. And here is a huge clinical pearl. The single most common cause of recurrence is simply poor compliance with that brace.
All right, before we leave the pediatric ward, let's rapid fire through some common MCQ traps. Examiners might try to tell you an X-ray is mandatory, but in reality, the diagnosis is primarily clinical. If an option claims surgery is first line, scratch that. The Ponzetti method is actually first line. And if a vignette describes clubfoot as a flexible deformity, you know better. True CTEV is rigidly fixed. Spot these little twists, and you'll sail right through those tricky exam questions.
Fantastic. Let's shift gears now. We're moving out of the pediatric clinic and heading straight over to the adult spine clinic. Let's take a look at Case 2, cervical myelopathy.
Let's read through this scenario together.
We've got a 62-year-old man who's had neck pain for a couple of years, but recently things have changed. He's developed clumsiness, difficulty buttoning his shirt, hyperreflexia, a positive Hoffman sign, and a spastic gait. This is a very specific, carefully painted clinical picture. I want to heavily emphasize that one phrase: difficulty buttoning a shirt. When you see fine motor clumsiness combined with all these upper motor neuron signs, what is the diagnosis?
You guessed it, it's cervical spondylotic myelopathy. The absolutely crucial point here is understanding the underlying pathology. This isn't just a simple pinched nerve in the neck. No. This is degenerative narrowing of the cervical spinal canal that's causing direct compression on the spinal cord itself. That direct cord compression is exactly why we're seeing upper motor neuron signs like spasticity and hyperreflexia. It is a very serious condition. If it's progressive, it often requires definitive surgical decompression, like an anterior cervical discectomy infusion, or ACDF, to prevent permanent irreversible spinal cord injury.
Now, examiners absolutely love asking you to differentiate myelopathy from radiculopathy. It's a classic setup. Just remember this: myelopathy is compression of the spinal cord, whereas radiculopathy is compression of a single nerve root. Because of this, in myelopathy, reflexes are actually increased. In radiculopathy, they're decreased. A Babinski sign? It'll be positive in myelopathy, but negative in radiculopathy. And their gait will be spastic in myelopathy, but totally normal in radiculopathy. Oh, and by the way, the absolute best gold standard investigation to confirm this compression is an MRI of the cervical spine.
If you need a quick, reliable memory trick for test day, just burn this quote into your brain. Myelopathy means many limbs. If you have a patient where both hands are clumsy and both legs have a spastic gait with a positive Babinski, don't get sidetracked thinking about a single nerve root. Think globally. Think spinal cord compression.
Let's travel a bit further south down the spine to see how this builds our clinical understanding. We're moving to case 3, another highly tested topic: lumbar disc prolapse.
Okay, here's our final clinical scenario. We have a 42-year-old man presenting with severe lower back pain that radiates straight down the back of his right leg. He says it gets way worse when he coughs. On exam, he has a positive straight leg raise test at 35 degrees. He's also got reduced sensation over his lateral foot and a noticeably decreased ankle jerk. So what is the diagnosis here? And honestly, more importantly, can you pinpoint the exact nerve root that's involved?
This is a classic lumbar disc prolapse, also known as PIVD. Now, the golden rule to remember here, and I guarantee this will be tested, is that in the lumbar spine, a prolapsed disc usually compresses the lower traversing nerve root. About 90 to 95% of these herniations happen at either the L4-L5 or the L5-S1 levels. So if a herniation happens at L5-S1, it reaches right down and compresses the S1 nerve root. And based on our patient's symptoms, S1 is exactly the nerve root being crushed.
To really understand why, we just need to compare the nerve roots. The S1 root supplies sensation to the lateral foot, it powers plantar flexion, and it mediates the ankle jerk reflex. Our patient had lateral foot numbness and a decreased ankle jerk. It just aligns perfectly. Conversely, if it were an L4 root issue, you'd be seeing medial leg sensory loss and a decreased knee jerk. And if it were L5, you'd be looking at weakness and great-toed dorsiflexion. Now, what's really brilliant about this is a simple little mental shortcut to lock it all in. S1 equals sole plus step on toes. If your patient has sole or lateral foot numbness, weakness when stepping on their toes, which is plantar flexion, and a reduced ankle jerk, you are for sure dealing with an S1 radiculopathy. But hold on, stop everything for a second. We absolutely need to talk about the red flags. If your patient with back pain suddenly develops urinary retention, saddle anesthesia, bilateral sciatica, or reduced anal tone, listen to me, this is no longer routine sciatica. This is cauda equina syndrome. It is a full-blown, absolute orthopedic emergency. It requires urgent, immediate surgical decompression. You don't just order a routine MRI and send them home to wait. You act immediately to save their neurological function.
Now, if it's just routine lumbar pivtide without any of those scary red flags, the management flow is very different. First line is NSAIDs and analgesics. Second, early mobilization and physical therapy. Notice I did not say strict bed rest. That's an old way of thinking. Early mobilization is highly encouraged as tolerated. And third, definitive surgery, like a lumbar microdiscectomy, is strictly reserved for when conservative treatment completely fails or if neurological deficits become progressive.
Let's finish up our spine review with one last look at some exam traps. If a question tries to tell you a CT scan is the best investigation here, remember that an MRI is absolutely preferred to visualize that soft tissue. If the options suggest prolonged bed rest, remember we just talked about how early mobilization is actually the key. And finally, a positive straight leg raise does not confirm a fracture. No way. It strictly indicates lumbar nerve root irritation.
With Section 1, Case 1, Colles fracture.
Picture this patient handoff in the ER. You have a 68-year-old osteoporotic woman who slips on a wet floor and falls on her outstretched hand. That is your classic foosh injury, right? She's complaining of severe pain, and on examination, her wrist is swollen with this very specific, highly testable dinner fork deformity. Luckily, her distal pulses and sensation are intact.
So, based on that classic clinical stem, what is the most likely diagnosis? Take a second and lock in your answer.
If you guessed a Colles fracture, you hit the nail on the head. Notice the defining features here. It's an extra-articular fracture of the distal radius, and it's characterized by dorsal displacement and dorsal angulation of the distal fragment. That dorsal displacement is literally what causes that classic dinner fork or silver fork appearance we saw in the stem. Always keep in mind that the median nerve is the most commonly affected nerve here, and malunion is your biggest complication risk.
Okay, moving to the management pathway. We're building this from the best initial investigation up. For suspected Colles, you always start with AP and lateral x-rays of the wrist. Your initial management on the floor is analgesia, assessing the neurovascular status, and immobilizing it with a splint. Now for definitive treatment, it really depends on stability. If it's undisplaced or displaced but reducible, a closed reduction and a below-elbow cast is your go-to. But if that fracture is unstable or intra-articular, you're looking at an ORF, an open reduction and internal fixation, and that's often done using a volar locking plate.
Now look at this slide. This is an absolute must-know differential for your Viva. It perfectly contrasts a Colles fracture with a Smith's fracture. While Colles comes from a foosh and features dorsal displacement with that dinner fork deformity, a Smith's fracture happens when you fall on a flexed wrist. That results in a volar or palmar displacement and gives you a garden spade deformity. Examiners love testing this distinction, so definitely burn this comparison into your memory.
Moving right along to Section 2, Case 2, Scaphoid fracture.
Here's the setup. A 22-year-old guy falls while playing football on an outstretched hand. When you examine him, he's got tenderness right in the anatomical snuff box, plus pain on axial compression of the thumb. But here's the catch. His initial wrist x-rays are completely normal. Given that perfectly normal initial x-ray combined with the snuff box tenderness, what's your diagnosis? And more importantly, what is your immediate next step?
Listen, you absolutely must treat this as a scaphoid fracture. Why? Because initial x-rays miss up to 30% of acute scaphoid fractures. It's a massive trap. Furthermore, the scaphoid is infamous because its proximal pole is at the highest risk for avascular necrosis, or AVN. This happens because the blood supply enters distally and flows proximally. It's a retrograde blood supply. So if you miss this fracture, that proximal pole can literally die.
The absolute most crucial point in this management pathway is to immobilize them first. Whatever you do, do not discharge this patient without a splint. Put them immediately in a thumb spica cast or splint. For investigations, MRI is your gold standard to uncover occult fractures early. But if an MRI just isn't available, you've got to repeat those x-rays in 10 to 14 days. Definitively, undisplaced fractures stay in the thumb spica cast, while displaced fractures or those at the proximal pole require an ORIF, typically using a headless compression screw.
Comparing the two foosh injuries we've discussed so far really highlights some stark differences. Scaphoid fractures typically hit young adults, present with snuff box tenderness, might completely hide on x-rays, and carry a huge AVN risk. On the flip side, Colles fractures strike the elderly, present with a glaring dinner fork deformity, are super easy to spot on x-rays, and their main complication is malunion. Keeping these two profiles strictly separated in your head is key to flying through clinical stems.
Let's shift down to the lower limb for Section 3, Case 3. Hip dislocation.
All right, here is your clinical stem. A 28-year-old man is brought into the ER after a high-speed road traffic accident. He was the driver, and his knee violently struck the dashboard. He's in severe pain, and his right hip is locked in a very specific position. It is flexed, adducted, and internally rotated. Plus, his limb appears visibly shortened.
Based on that classic dashboard mechanism and that very specific limb presentation, what is the diagnosis, and which specific nerve is most commonly injured and must be documented? This is a posterior hip dislocation, which accounts for a whopping 90% of all traumatic hip dislocations. And the nerve you must check? The sciatic nerve, specifically its common peroneal division. It is absolutely vital to document foot dorsiflexion and sensation over the dorsum of the foot both before and after you attempt any kind of reduction.
Take a look at this slide. Notice the stark contrast in limb positioning between the common posterior dislocation and the much rarer anterior dislocation. A posterior dislocation is flexed, adducted, and internally rotated. If you walk into a room and see a hip that is extended, abducted, and externally rotated, you are looking at an anterior dislocation. Know the difference, because the clinical STEM is going to paint exactly one of these two pictures for you.
For definitive management, treat this like the emergency it is. You follow your ATLS protocols, provide adequate analgesia, and start with an initial AP pelvis X-ray. The absolute most critical step here is an urgent closed reduction within 6 hours. Delaying beyond that 6-hour window drastically increases the risk of avascular necrosis of the femoral head. Finally, you follow up with a CT scan post-reduction to check for any intra-articular fragments or associated posterior wall acetabular fractures.
Let's bring this all together. Section 4. High-yield exam pearls.
Okay, here is exactly where the examiners try to trip you up. Firmly remember, Colles displacement is dorsal, not volar. The median nerve is at risk in Colles, not the ulnar nerve. Scaphoids often hide on initial X-rays, so a normal film means nothing if that snuff box is tender. The proximal pole of the scaphoid, not the distal, has the highest AVN risk. And finally, posterior hip dislocations are internally rotated, not externally.
To completely lock in case 1, memorize this one-liner right now. Cold dinner served with a fork pointing dorsally. Let that instantly remind you, Colles equals dorsal displacement, which equals the dinner fork deformity. Say it a few times in your head, and you will literally never confuse it with Smith's again.
And for our last 2 cases, keep these rules absolute. Snuff box tenderness means scaphoid fracture until proven otherwise, regardless of what that X-ray says. And for the hip, a dashboard injury means you must dash to reduce that hip within 6 hours to save the femoral head from AVN.
Case 1, cauda equina syndrome. This is a scenario that is constantly tested in MCQs, clinical vivas, and ward rounds.
So, picture this scenario. We've got a 45-year-old man who comes in after lifting a really heavy object. Over the next 24 hours, he develops severe low back pain, bilateral leg pain, difficulty passing urine, numbness around the buttocks, and weakness in both legs. Listen carefully to those symptoms, especially the bladder ones. Take a quick second. What's the most likely culprit here?
Well, if you were thinking cauda equina syndrome, or CES, you nailed it. This is a true, undeniable orthopedic emergency. The most common cause you've got to know for your exams is a massive central lumbar disc prolapse, and that usually happens at the L4, L5, or L5S1 levels. Now sure, tumors, trauma, or epidural abscesses can cause it too, but always think of that massive central disc herniation first.
You absolutely need to know the 5 cardinal red flags for this. Examiners expect you to just rattle these off without even blinking. We're talking severe low back pain, bilateral sciatica, saddle anesthesia, bladder dysfunction, and reduced anal tone. But here is the major IMM exam pearl. Urinary retention is the single most important and most predictive sign. Never miss it. Basically, if a patient with back pain can't pass urine, you have to assume it's cauda equina until proven otherwise. But why does this matter so much compared to a standard lumbar disc prolapse? Well, a standard disc prolapse usually gives you unilateral sciatica, no bladder symptoms at all, and you usually just manage it conservatively at first. Cauda equina, totally different beast. It's almost always bilateral, features highly prominent bladder and saddle symptoms, and demands immediate surgery. You absolutely cannot delay definitive treatment for conservative therapy here.
So what's your management sequence? First things first, admit them urgently and assess that bladder function. Get a post-void residual scan. Next up, you must order an emergency MRI. Make no mistake, that is the absolute gold standard investigation to figure out the level and degree of nerve compression. And then, immediate surgical decompression, which is usually a lumbar discectomy. Early decompression gives the patient the best possible chance of neurologic and bladder recovery. If you wait around, they're facing permanent bowel, bladder, and sexual dysfunction.
Watch out for these classic MCQ traps, guys. Examiners love to see if you know that cauda equina is a lower motor neuron or LMN lesion. Why? Because the cauda equina is made up of peripheral nerve roots. It's not an upper motor neuron lesion like cervical myelopathy. Also, remember, MRI, not a CT scan, is your investigation of choice. And don't be fooled, normal leg power doesn't exclude CES. Early on, it might literally just be bladder or sensory symptoms.
Here's a golden one-liner to just burn into your brain. Saddle plus bladder equals straight to theater. Seriously, if you see saddle anesthesia and urinary retention, do not assume it's routine sciatica. Think cauda equina, get that MRI, and page surgery immediately.
All right, moving right along to Case 2, lumbar spinal stenosis. This is another exam favorite, where telling symptom patterns apart is the whole key to the puzzle.
Here's your next scenario. We've got a 68-year-old guy with bilateral leg pain that kicks in after walking just 100 meters. But check out this specific detail. The pain gets better when he sits down or leans forward on a shopping cart. He's got normal foot pulses and totally normal bowel and bladder function. Think about that unique pattern of pain relief for a second. What are we looking at here? Yep, it's lumbar spinal stenosis. This is essentially a narrowing of the lumbar spinal canal, which ends up compressing the cauda equina and those nerve roots. In an older patient like this, you're usually looking at degenerative disc disease, facet joint hypertrophy, or a thickening of the ligamentum flavum as the root cause.
The absolute hallmark symptom here is neurogenic claudication. It's a great term because it perfectly describes how a patient's posture actually changes the physical compression on their nerve roots. The pain hits both legs when they walk, but, and this is key, it improves with sitting or lumbar flexion. Why does that happen? Because bending forward literally opens up the spinal canal a tiny bit, which takes the pressure off those nerves. Standing up straight or walking downhill does the exact opposite. It extends the spine, narrows the canal, and makes the pain so much worse.
You know, examiners are going to test you on neurogenic versus vascular claudication. It's a classic. Notice how neurogenic claudication requires sitting or bending the spine forward to get relief. Vascular claudication, which comes from peripheral arterial disease, gets better just by stopping and resting. Plus, with neurogenic, those foot pulses are perfectly normal, whereas with vascular, they're reduced or totally absent. For diagnosis, an MRI of the lumbar spine is still your go-to to actually see that canal narrowing and ligament thickening. But the management here is a lot different than our first case. You almost always start conservatively. Think physiotherapy, NSAIDs, modifying their activities. You only really jump to a definitive surgery, like a lumbar decompressive laminectomy, if the symptoms become severely disabling or if they develop a progressive neurological deficit.
Just lock this visual in, the shopping cart sign. If a vignette describes an elderly patient leaning forward on a shopping trolley in the grocery store to relieve their bilateral leg pain, that is the textbook slam dunk sign of spinal stenosis. When you see that, you know exactly what the examiner wants.
Okay, let's switch gears to trauma with Case 3, open fractures. This is an incredibly high-yield topic. Examiners are going to scrutinize your step-by-step emergency management and your grasp of classifications.
Imagine you're in the ED. A 27-year-old guy is rolled in after a nasty motorcycle accident. He's got a right tibia fracture, a 10-centimeter laceration, the bone is exposed, and it's heavily contaminated with soil. Crucially, though, his distal pulses are palpable. Ask yourself, how are you classifying and initially managing this?
Right off the bat, this is an open or compound fracture of the tibia. A little fun fact for your exams, the tibia is actually the most common bone involved in open fractures, simply because it sits right under the skin and is super vulnerable.
You absolutely have to know the Gustilo-Anderson classification. You just have to. It dictates your entire management strategy. Type 1 is a clean wound under 1 centimeter. Type 2 is between 1 and 10 centimeters with moderate tissue injury. But Type 3 is where examiners love to dig in. Type 3A has extensive soft tissue damage, but you still have adequate coverage for the bone. Type 3B means extensive periosteal stripping. Bare bone is exposed, meaning you'll need a soft tissue flap. And Type 3C, that's the most critical. It can be any size wound, but it has an associated arterial injury that requires vascular repair. And here is a brilliant memory trick for those tough Type 3 categories. A is for adequate soft tissue. B is for bare bone. And C means circulation is lost. If you see an arterial injury, boom, it's automatically a triple C, and you're looking at a very high risk of amputation.
Okay, a quick warning on clinical traps here. Do not reduce the fracture before you give early IV broad-spectrum antibiotics and update their tetanus. You just don't. Early antibiotics are literally the most critical step to prevent infection. Also, don't fall for the idea that you should just stitch up all wounds immediately in the ED. Nope.
These injuries need urgent, formal surgical irrigation and debridement in the operating room before you even think about definitive stabilization and closure.
Finally, let's wrap this up with the high-yield trauma golden rules that apply across the board. No matter what, always stick to the IMM trauma golden rule sequence. Treat the patient first, then the fracture. Always begin with your ATLS ABCD resuscitation. Don't get distracted. Only after the ABCDs do you move to a neurovascular exam and get your x-rays. If it's an open fracture, that's when you give those IV antibiotics and apply a sterile dressing. Then you splint it and finally arrange for definitive surgical fixation. Getting this logical flow down cold is how you crush your boards. So as we wrap up today, I'll leave you with this thought. When you're in the middle of a chaotic trauma bay with alarms blaring and everyone rushing around, will you remember to secure that patient's airway before you even look at their shattered bone? Keep that priority straight and you're going to do absolutely brilliantly.